So first I'm going to start by looking at the general appearance of the patient. Can you take your shirt off, please? All right, so I don't see, just breathe normally for me. I don't see any excessive work of breathing, no use of accessory muscles when breathing. Patient is at ease. No cyanosis of the lips or the nail beds. Cap refill is less than 3 seconds. I'll take a look at the trachea, place my fingers at the sternal notch and make sure that the trachea is midline, and that is midline. I don't hear any audible wheezing or any audible sounds when he's breathing in and out. And I will go ahead and count his respiration, so just go ahead and breathe normally for me. Okay, respirations are about 16 per minute. There was 4 in those 15 seconds. Times that by 4, we're going to go ahead and get 16 respirations per minute, which is normal for an adult. So now I'm going to go ahead and palpate. I'm going to check the anterior, posterior, lateral dimension. So I'm going to come over to the side if you can, and I'm going to measure the lateral. There. Measure the front, which is equal for a 2 to 1, which is normal. So AP and lateral dimensions are 2 to 1. And then I'm going to test for tactile firmitis. So I'm going to place my hands on your back. When I place my hands on your back, please say 99 over and over again.
99, 99, 99, 99, 99.
Okay, you can stop. So vibrations were equal in intensity and on both sides and throughout the lungs. So now I'm going to go ahead and palpate. I'm going to look for any bruising on the front or the back of the patient. And while I'm palpating, I'm also going to feel for any bony deformities or any nodules that I can feel. You tell me if you have any pain when I press. Any pain there?
No.
Okay. Any pain there?
No.
Okay. So now I'm going to check for tactile firmitis. So by doing that, I am going to, not tactile firmitis, chest expansion. So I'm going to place my thumbs at about close to the spine at about the 10th rib and place my fingers lateral to the thorax. Have the patient breathe in and out deeply. One more time. And chest expansion was, the diversion of my thumbs was about 2 centimeters, which is normal. Okay, so now I'm going to go ahead and percuss. So since I am at the front of the chest, I'm going to go ahead and start palpating, making sure that I use only the distal portion of my finger, so that way I don't damp out any of the resonance or any of the vibrations that I'm going to feel. So I'll start above supraclavicular. Okay, that was resonant. And then I will go ahead and do the back. Okay, so back and front of the chest are resonant. If I felt hyperresonance, it would mean that there were air in the lungs. If I felt any dullness, it could mean that there was fluid or that I was just percussing over a dense organ. So after the percussion, I am going to come back to the back and I have to test for diaphragmatic excursion. So I'm going to start from an area of resonance and go down until I feel dullness, and then measure that from end to beginning. And diaphragmatic excursion is about 3.5 centimeters, which normal would be 3 to 5. So that's normal. So now I'm going to auscultate and take a listen to the lungs. So if you can just breathe normally for me with your mouth open. And deep breaths. Okay. And listen to the back. Deep breaths. And I'm making sure to go in a ladder position to make sure we don't go any of the bony portions of the body. And lungs are clear bilaterally to auscultation. I don't hear any wheezing, bronchi, rales, which could indicate air fluid inside. Now I'm going to go ahead and auscultate the front of the chest and check for bronchophony. Go ahead and just breathe. And go ahead and say 99 for me, over and over.
99, 99, 99, 99.
Okay, you can stop. So vibrations were, I could hear it very lowly, low pitched. So that is normal. If it were high pitched, there would be some abnormalities there. But it was a low pitch. So now I'm going to test for egophony. When you feel my stethoscope placed on your back, if you could please say E, E, E. This is going to check for any egophony.
E, 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 E. E, 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 E. E, 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 E. E, 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 E.
Okay. So that was also very low pitched, and I did hear the long E sound. If I were to hear a loud A sound, it would mean that there was underlying consolidation, which would mean that there was fluid in places that air should be. So now I'm also going to check for whispered pectoriloquy. I'm going to place my diaphragm on the back of the patient's back. And if have you whisper 1, 2, 3 when you feel my stethoscope touch your back. Okay, and so I didn't hear any whispering on that, which is normal. If you heard loud sounds, it again would also mean underlying consolidation. And then if for some reason when I was listening to the lungs I heard any adventitious sounds, I would test for post-tussive sounds, And what that would sound like would be a hissing sound on inspiration. But we didn't have any adventitious sounding, so that's not an issue here.